CAR T-cell therapy has really to this point been developed in the B-cell malignancies and is in phase 2, phase 3 clinical trials. For AML, CAR Ts are starting to enter the clinic. So first we need to overcome some of the expected toxicities that we see with CAR T-cells that we're already seeing with the B-cell malignancies, which are the cytokine release syndrome, neurotoxicity. Specifically in regards to AML, the CARs are targeting a different antigen, commonly CD123, CD33, and these are also expressed on normal hematopoietic progenitor cells. So you start to run into problems with myelosuppression, low blood counts, and those challenges will have to be overcome before they're widely implemented into clinical practice. The second thing for AML, I think, is that these patients are rather sick, they're rather debilitated when they've gotten to a point of refractory disease. And it takes a while to manufacture the CAR T cells. It can take as long as 2 to 4 weeks. And so in that period of time, you really have to maintain the patient on some sort of treatment so they remain in a condition in which they're strong enough to receive the CAR T cells. So I think improving the manufacturing process such that the cells are manufactured quicker and provided back to the clinician in a timely manner will help with the development of these therapies in patients with AML. So primary refractory AML can be a very difficult patient population to enroll onto clinical trials. And the reason is, by the time patient has become refractory to upfront chemotherapy, oftentimes they are struggling with infections, toxicities of the chemo, organ toxicity, kidney failure, elevated liver function tests, and all these things typically exclude a patient from being on a clinical trial. So to find a patient who, despite undergoing upfront therapy, being refractory, who has not encountered the common complications, infections, toxicities that we see, and who would be eligible for a clinical trial is difficult. The other thing is second-line standard of care therapy for AML is not terrific. The outcomes are not great. And so to try to convince a patient to be randomized to an intervention that might not be especially effective can be very difficult. Oftentimes, in randomized trials, we enroll patients who get enrolled to the standard of care arm, unfortunately often drop out of the trial because they wish to pursue another therapy. So trying to convince patients to stay in a trial in which the standard of care arm might not be their best option can be very difficult. There's several presentations at ASH this year in regards to antibody-based therapy for AML. There were two presented, one by Harry Erba, in which SGN-33A was combined with 7+3 induction chemo for patients with newly diagnosed AML. So what SGN-33A is, it's a monoclonal antibody drug conjugate. It's an antibody directed against CD33, and it's conjugated to a pyrrolobenzodiazepine molecule, which cross-links DNA, causing DNA strand breaks and cell death. And SGN-33A at ASH last year was presented in several abstracts, mainly in patients who were elderly and unfit for high-dose chemotherapy. One abstract by Dr. Fadi demonstrated approximately 25 to 30% single-agent response, CR response, with SGN-33A alone, which is very encouraging. And that was primarily in relapsed and refractory patients. In regards to newly diagnosed elderly patients, another abstract last year showed a 60 to 70% response rate when combined with the hypomethylating agent. So this year, we are evaluating SGN-33A in a younger patient population who is fit for high-dose chemo. Dr. Erba's study demonstrated that it could safely be given with 7+3 chemotherapy. As with the CAR T cells, which target the myeloid antigens, the biggest dose-limiting toxicity that we experienced was myelosuppression, which was overcome with just lowering the dose. The response rate was very high, with often a single course of induction. And I think more importantly, a lot of the patients who achieved a complete remission achieved a MRD negative complete remission, which we now know predicts for improved outcomes long term. A second abstract presented by Dr. Yang of Carmanos looked at combining SGN-33A with consolidation chemotherapy, high-dose cytarabine, and then also looked at it in the maintenance setting, both following chemo and then following allogeneic stem cell transplant. And again demonstrated that the major toxicity was myelosuppression, but that at lower doses, SGN-33A could be combined with chemotherapy. Another oral presentation at this ASH was looking at SL401. That is a antibody that targets the IL-3 receptor alpha, and it's conjugated to diphtheria toxin. And basically, the study evaluated patients who had minimal residual disease after their upfront therapy and enrolled them and then administered the antibody. And we found that this antibody could be given safely, and also there was a suggestion that in several patients they went from being MRD positive to MRD negative after receiving the antibody. So these, along with other antibodies, are antibodies targeting CD123. There are bispecific antibodies in which one arm of the antibody targets a myeloid antigen, the other arm targets the CD3 on the T cell, and then promotes T cell killing of the malignant cell. So there are a lot of promising therapies in regards to antibodies being used for AML.